Just past 8. Good evening, everybody. Thank you for joining us for this webinar on bone health optimization. My name is Keith Jackson, and I am the moderator for this conversation. I'd like to welcome and introduce my faculty, Dr. Brett Friedman from the Mayo Clinic in Rochester, Minnesota, and Dr. Scott Daffner from West Virginia University in Morgantown. Appreciate them. I told them before they're about the two smartest guys on this topic that I really know. So it's so great. I'm looking forward to learning from them tonight. Here are our relevant disclosures. We go through before this and vet these, and there's really no implant conversations or specific implant conversations, and we don't anticipate these being relevant disclosures to this conversation. A little bit about the AO with the validation statement. AO is an independent nonprofit surgical specialty dedicated towards education. It does not endorse or promote the use of any product of any type. There will be pictures of implants used. They're just for teaching purposes only. Here's an overview of what we're going to accomplish. It's a very wordy slide. I apologize for it, but as the general population of the United States ages, we're seeing more and more patients presenting with elective spine problems at later stages of life. We're encountering things like osteoporosis more and more as spine surgeons. Understanding how to screen, how to diagnose, and how to treat is paramount to attaining optimal surgical results. Here are the learning objectives for tonight. And here's our agenda. Okay, so starting out with a case, this is one of my own, and I've mentioned to both of the faculty that this is not a case I've done yet. I met this lady about a year ago. She's got some challenges that we're trying to get her optimized as possible, and so we're working it. But I'm anxious. I think it's a good illustrative case of a patient who comes in with really bad bone quality, and what we need to do. And so this is a 63-year-old female who presented to my clinic with right leg pain and neurogenic claudication. She is able to stand and has normal strength, but develops a lot of fatigue from both back pain, mechanical back pain, and the reproduction of radiculopathy after about 5 minutes. For that reason, when she's out and about in the community, she actually uses a wheelchair. Her past medical history currently is only significant for hypertension, but she's had a history of bulimia that she's never been able to put a ton of weight on afterwards. Past surgical wise, she had an L4 to S1 decompression in 2005 and an L3 to S1 AP fusion in 2017, where she had an ALIF and then a posterior fusion with a TLIF at 4.5 and instrumented fusion at 3.4. On physical exam, one of the most notable things about her is that she's underweight. Her BMI is 17. She has a healed midline surgical incision and a healed Banasteel incision. She's in a wheelchair but can stand with an obvious sagittal imbalance. She has 505 strengths and her sensations intact from L2 to S1. Prior to coming in, she had tried an extensive course of everything to include physical therapy, oral medications, injections, and it had a spinal cord stimulator. Because of her size, she always had a hard time with the prominence of the battery pack, so they took that out but left the leads, and so it's a non-MRI compatible spinal cord stimulator, and because of that, she had a CT myelogram. It showed L2 to L2-3 central lateral recess and foraminal stenosis, worse on the right side in the lateral recess and foramen. The remainder of the spinal cord was patent, and she had a solid fusion from L3 to S1. So as we get into some of her global spinal parameters, her SVA was a positive 8 centimeters. She has a lumbar lordosis of 40, a thoracic kyphosis of 41. Her CSVL is 1 centimeter. Her pelvic tilt is 28 degrees. Her sacral slope is 32 degrees, and she has a pelvic incidence of 60 with a mismatch of 20 degrees. because of her age, her gender, and her history of bulimia, I obtained a DEXA scan as part of the initial workup. It showed T scores negative 4.2 in L1, negative 3.2 in the femoral neck, and negative 5.4 in the distal radius. So with the diagnosis, that kind of gets us into the night, is a segue into tonight's topic, which is osteoporosis. Osteoporosis is a part of a continuum of decreased bone mineral density that occurs with age. Just like every other part of life, life is a catabolic state. We develop peak bone mineral density at about 25 years of age, and then it's a slow decline from there. It's part of a continuum. We start out as we lose bone mineral density, we go to low bone mineral density to osteopenia, finally to osteoporosis. The diagnosis is made in a number of different ways: a history of fragility fracture, low bone mineral density on DEXA scan, or now a CT scan with low Hounsfield units, or a fracture risk scoring system, or the FRAC system, can all trigger the diagnosis. The reason why we care about this as spine surgeons is because it's been correlated with higher rates of implant failure, higher rates of proximal junctional kyphosis. It doubles the rate of pseudoarthrosis and triples the rate of overall revisions if not addressed preoperatively. And so it really challenges many of the instrumented cases, particularly the long segment or deformity type cases that we're doing more and more of. Whereas into the demographics, decreased bone mineral density is quite common in the United States population, particularly as we age. 43.1% of the U.S. population over the age of 50 has a diagnosis of osteopenia, and 12.6 of those have osteoporosis. It's much more common in females as well, particularly white and Asian females. 19.6% of females over the age of 50 in America have osteoporosis compared to 4.4% of the male over the age of 50 population, according to the World Health Organization. As we look at demographics, it's a problem that's increasing. In a kind of survey of our national population and the incidence of osteoporosis, you can see the blue line in between shows an increase between 2007 to 2017. I think it's notable that the male rate remained about the same. So the increase in the overall population is 100% related to an increased incidence in the female gender in our country. When we look at the specific population that is undergoing spine surgery, we see high rates of both osteoporosis and osteopenia. In a systematic review and meta-analysis of 2,958 patients, FAN reported an osteoporosis rate of 34.2% and an osteopenia rate of 43.5%. They found significant associations between the presence of osteoporosis and female gender, age greater than 60, degenerative lumbar scoliosis, and compression fracture. So while some of these can be just sort of deduced through logic, the presence of degenerative lumbar scoliosis may not be as straightforward. And so I'm going to turn it over to Dr. Friedman now, who's going to talk to us a little bit about the diagnosis and perioperative management of this condition.
Thank you, Keith. Are we seeing the slides?
Mm-hmm.
All right. Well, thanks for inviting me, and thanks for organizing a topic, a webinar on a topic that's quite important. You saw in that case a lot of key elements that are very true to us. The largest growing segment of patients undergoing fusions, especially long segment fusions, are people over the age of 65. Along with that, you see that they have a higher degree or higher percentage of diminished bone quality. And so I was tasked with talking about two elements of this issue. One is screening and diagnosis of osteoporosis, and the other is some of the things we can do as surgeons to address it. So why is it important to screen and then diagnose? Well, you can't find what you don't look for, right? So we got to screen. And you can't treat what you don't diagnose because absent one of these four FDA-approved indications, the expensive medications I'm going to want you to use won't be authorized. And so we need to look deeper. You can see the iceberg there on the right side. If all you have is DEXA scan, you're just going to see what's above the water. There's a lot of osteoporosis lying underneath, and you got to look for it. And then once you do find it, then you got to treat it. And of all the treatments that exist, the one that actually can influence your outcomes will be the anabolics. So what's going on here? And as Keith pointed out, it's a very prevalent. This is another study looking at a large number of patients undergoing adult spinal fusion surgery. 50% of women, 20% of men had osteoporosis within that subset. So very, very prevalent in the patients we're treating. We all, I think, are aware of the DEXA scan, and certainly this is a tool. You saw in Keith's patient that the patient had horrendously low T-scores. Minus 5.4, I think, was the lowest. And so you look on your T-scores, you look at the lowest T-score, that's the one you're going to choose to define whether or not they have osteoporosis. I imagine we're all familiar with the WHO criterion. If it's less than 2.5 standard deviations below a young healthy mean, then you have osteoporosis. And back on Keith's patient, another column you can look at is this other column here, which is the grams per centimeter squared. When that number is less than 0.6, that's my number that says this will not hold a screw because butter does not hold screws. And that's when you actually have formally identified butter instead of bone marrow. So that's a secondary thing you can use for getting information from your DEXA scan above and beyond the T-score, and also something else we won't talk about tonight, but there's a trabecular score that also comes out of DEXA. So why do we want to look so hard? Because DEXA is far from perfect. 1 in 6 patients with a fragility fracture will have a normal T-score. The majority of fragility fractures happen in people with T-scores that are in the osteopenic range. It's the bone implant interface that is the weak link in the surgeries we perform on people with diminished bone quality. And so we need to find it. The reason why we became so interested in it dates back to 2018. Why we were paying attention to it before, we really got into the game when we looked at our cases. We looked at 140 consecutive patients who underwent a posterior thoracolumbar fusion, and mixed within that was sort of the distribution you'd expect to see. 31% were normal by T-score, 59% were osteopenic, and 10% were osteoporotic. In that group, 1/3 had an osteoporosis-related complication. You can see what those are on the left. And of those 1/3 that had a osteoporosis-related complication, 84% were deemed to either have normal or osteopenic bone prior to surgery. So DEXA is definitely not enough for us to understand. Here's an example of a patient, 65-year-old female, preoperative T-score is minus 1.7. So by WHO criteria, this is osteopenia. This is an older patient. And so you can look down here, you see that little region of interest and the number 100 in it. That's the HUs, and the HUs of L1 in this particular patient were 100. We'll talk about the fact that that probably was a harbinger of the patient having osteoporosis. But back when we did this case, that was what we had. That's what we did. And we did not diagnose the osteoporosis. She did not get treated. And you can see she developed a PJF. They can happen in people with normal bone, but the softer the bone, the more I think that's a problem and something that we should do something about to try and reduce in our optimization phase. So what can you do? You can look at a lot of different directions. So you can look at the direct DEXA-derived means for assessing bone health. And so we've talked about those some, the DEXA, the T-score, trabecular bone score. And then there's a perturbation you can do off of a DEXA scan called a VFA, vertebral fracture assessment, which we'll talk about in a bit. You have the predictive way, so the FRAX developed out of Sheffield, England, in which a series of 12 questions gives you a risk of having either a major osteoporotic or a hip fracture in the next 10 years. You can use clinical diagnosis. If you have a spine fracture or a hip fracture that is of a fragility mechanism, then you have osteoporosis. But unfortunately, 2/3 of spine fractures are asymptomatic, and so you got to look for those. And we'll tell you again ways you can do that. And then you have the CT methods. Now, the classic was a QCT, which gave you a volumetric bone density, which is better than the aerial bone density you get from a DEXA scan, but a lot more radiation, and you actually have to do it in a special way. So that's not so practical. But since we get a lot of CT scans on patients undergoing spine surgery for anatomic reasons, we can then do that region of interest I showed you, identify the HUs, and we've done it enough now to start to get an idea of what those numbers should be. And then lastly, a very fine-tuned way of doing that is actually BCT, biomechanical CT testing, goes by the trade name Virtuost. It's another FDA-approved method for using imaging to detect osteoporosis. So going through some of the ones you might not know, vertebral fracture assessment. So essentially you can render a 2D view. You usually get up to T4 to T7 using this method. You can see it's a nice, pretty picture. And essentially what they do is they measure the posterior, the middle, and the anterior height, and you look at the ratios between those. If that ratio suggests that there's a 20% or greater wedging, then you have a fracture. This is a fun tool for two reasons. A, remember if you have a fragility fracture, and so if the patient doesn't remember a history of a trauma that caused it, then it's a fragility fracture. If you have a fragility fracture, then it doesn't matter all the other numbers. Boom, already got it. You got the osteoporosis because you got to diagnose to treat. And so this is a great way to identify those patients that are passing through the DEXA method because they have too much spondylosis, for instance, that is causing their T-score to be artificially high. And the other thing is that you will see later is that when you have multiple fragility fractures, you actually can qualify directly for antibiotics. And so this is another way to detect multiple fragility fractures. The FRAX tool we said is these 12 different risk factors. They're there on the left. You put them into a calculator. If you go to that website, you could do it yourself. And it comes out with two outputs, 10-year risk fracture of a major osteoporotic fracture and 10-year risk fracture, 10-year risk of a hip fracture. Just remember Michael Jordan's number, 23. So it's 20% for the majors or 3% for the hip. Either of those, if you're higher than them, then you're indicated for intervention. You have osteoporosis. And then the newest kid on the block is this Virtuos test. It's from a company called O&D Diagnostics. Tony Chiavini is the lead on that. He's the smartest person I know on using imaging to assess bone strength. And so this is a nice tool. We're using this regularly now. It's FDA approved for the diagnosis of osteoporosis. I'll show you a couple examples here of what it looks like when they do it. But essentially, it's a FDA model of the bone. They simulate compressive loads that are within the human range, and they see when the bone would fail. And this is what the output of that test looks like. You send them in a CT. It's their normal anatomic CT, so you didn't have to use a phantom or any kind of special protocol. You just send in your normal CT scan. It can't be contrasted, so a non-contrast CT, which is usually not a big deal for us. And they usually go to a nominal vertebra, typically L1, and they'll go and they'll do the simulation of how much load it'll take. It comes out on this scale here, determining what the strength of that bone was. This one was predicted to fail at 4,300 newtons, which would put it in the fragile range. And then based on this output and the volumetric BMD, they come up with a classification of osteoporosis, again, diagnostically approved by the FDA. And so this could have said osteopenia, osteoporosis, or normal. This is an osteoporotic patient. And then this is sort of the readout that you'd get on your normal EPIC or radiology report. Again, identifying that the patient has osteoporosis, identifying that the bone is fragile, giving you the sort of the ranges of what fragile is. So this is a neat tool. We can also, you can see down here, we can make call outs where our UIV or LIV is going to be. So we can see, is that a good stopping point? So we're still new to this test to see how to use it better than just identifying osteoporosis. We talked a little bit earlier about HUs, and so HU, everyone can do this on their PAC system. If you take your circle or elliptical tool, you make a circle as big as you can make it that doesn't touch any cortice or the the vein foramen here. Then you right click in that, and when you right click on almost every PACS I've seen, you'll have the opportunity to make it be your HUs. This particular patient, 220, picked because this is a L5S1A lift. This is going to be young, healthy, good bone. This is what it should look like. So when you're knocking that and it says 80, that's not good bone. And so what do we do? Well, the person I know that knows the most about this is a guy named Paul Anderson. He's a spine surgeon that just recently retired out of University of Wisconsin. And the person he knows that knows even more about it than him is a guy named Neil Binkley, who's a lead endocrinologist on the topic of bone health. And so they did a study in which they looked at a bunch of patients that were young and healthy, sort of the way that you set up the DEXA scores. And they said, well, this is what young, healthy people look like. They look like they're about 230. And then if you look at the standard deviation, 2 standard deviations below the mean was about 130. And so they said, so if you're about over 130, then you might be in the normal or osteopenic range. Once you get down to the 100 and the 110, and unfortunately, a lot of people have done this. They haven't done it in a normative fashion. And so you can see a lot of different numbers out there. 100, 110, that or below, for sure, osteoporosis. 110 to 135, somewhere in that range. And 135 or certainly more than 150, then you're probably going to be normal by any metric we use to identify osteoporosis. This is not a diagnostic that will support medications, but it may be a screening tool. We do all the tests I just showed you. So maybe that's not financially appropriate, or maybe you don't have resources to, access to those. Fine. Use this free thing because you have a CT to figure out how you're going to do your surgery. If you get something in the low hundreds, then feel that you need to go further. Send your CT to get the Virtuos test. Ask for a VFA. Do one of the other things I just mentioned to you to identify that osteoporosis underlying the water. So once you make this diagnosis, then what do? Well, there's things you can do before surgery. There's things you can do during surgery. Post-operative is too late, right? So before surgery is this concept of bone health optimization we'll walk through. That's screen, diagnose, treat, win. Intraoperative things you can do. My mantra is less bone, more metal. And so we want anterior and posterior column support. Augments, you can, cement or not cement. That's a question for us to debate, I suppose. So what is bone health optimization? Going back to, again, Paul Anderson, Neil Binkley. I think they're leaders in the field on this. And Paul was the original leader of the Own the Bone health initiative that's run out of the AOA. A great thing. Anyone has questions about fragility fracture, fracture liaison management, and even this, they have wonderful resources I would direct you to. And their recommendation is running a standardized systematic approach to identifying osteoporosis and then leading to treatment in all their spine surgery patients over the age of 50. And so the goal of BHO is you identify the bad bone and then you do something about it. You either improve it before surgery by modifying modifiable factors like stop smoking, don't drink too much, vitamin D supplementation, we'll talk about that a bit, and then getting them on anabolics, and we'll talk about what that means. Or you could respond to that, and that's that less bone, more metal thing I mentioned, and then optimize bone grafts. So bone health optimization is it's a 2 to tango kind of phenomena. You got to be willing to find someone that can be a medical doctor for this chronic illness. It's not common that a surgeon treats chronic illness. And so in our facility, we're blessed to have endocrinologists that are very interested in bone. And so they actually come into our clinic and they're there with us a few half days per week. And so we can directly say, this is the patient indicated for a big surgery. Just looking on the screen, we know that they've got something or they've done a fair amount of the work already. And we've identified that they have diminished bone quality. I apologize if I talk too fast. When I get excited about something that I care about, I talk faster and I talk louder, but I think this is getting you mute down. But I want to make sure you get all this stuff. But the 2 to tango is a key element of a success. Wherever you are, identify that person that you can work with. It might be a rheumatologist, it might be an OBGYN if it's female patients, somebody that you feel comfortable working with, and explain to them why you want anabolics rather than a bisphosphonate or a first-line agent for someone that you found that has osteoporosis. Together you can win. So vitamin D, very important for calcium and phosphate metabolism. There are multiple different recommendations for how much you should take in a day. 800 IUDs is sort of the most common. Vitamin D only works if you have enough calcium. So you need about 1,000 to 1,500 milligrams of calcium per day. You can only take calcium about 500 milligrams per time. So if you take 3 pills in the morning, you're only going to get 500. So you split it over the course of the day. Citrated calcium absorbs better. In vitamin D, the lab you do to check for vitamin D is called the total vitamin D, or the D2 plus D3. And that lab, there's multiple different normals ranging between 20 and 50. We pick 30. And so if you're over 30, we assume you have adequate vitamin D levels. If you're under 30, then we want to do something about it. And we have this very complicated thing that was sort of a level 5 expert opinion, distilling different information out there to come up with how we're going to do. We've been running this as sort of our internal method for vitamin D supplementation. Turns out you can take a ridiculous amount of vitamin D before it's toxic, 60,000 units for several months before it's toxic. So even though there's some big numbers on here, don't be concerned. When you do identify someone that is low with vitamin D, then assume that they've been low for a while. So it takes a while to get them back up. Our supplementation plans, which are the 1,000, 2,000 units, depending on how bad they were when we met them, that should run out for a year. These are all over-the-counter medicines. These are recommendations. Just like we recommend lose weight, exercise, we're going to recommend that you take your vitamin D supplement for the next year. But this is the thing that actually makes a difference. So anabolics, there's 3 of them that are currently FDA approved in the United States. Forteo is the commercial name for teriparatide, Tymlos for abaloparatide, and Evenity for romosozumab. So Forteo, Tymlos, they're about the same. They are PTH analogs, and so they work like parathyroid hormone. They are administered by the patient. They take 2 years to be fully done, and they're considered by Medicare a drug. And so there's some reimbursement issues with that. Evenity is given by a provider, therefore it's a procedure. As a procedure, it's under Medicare B for most ways in which it's assessed, and that usually allows a greater access to care for those patients. And it only takes 1 year, so you get an accelerated rate to get to what you want to be. You should know that there are indications by the American College of Endocrinologists that identify reasons to go directly to anabolics as opposed to the cheaper bisphosphonates. If you have multiple fractures, we talked about that with the VFA, you can find those. If you have very low T-score, like Keith's patient, either of those would be direct indication to go to anabolic. And by going to anabolic, you go to the thing that actually drives outcomes. The only other way you get there is fail a first-line agent. Failing a first-line agent can be by having a fracture while on one, or it could be that I can't tolerate the very prescribed way in which you take an oral bisphosphonate, which is actually an easy way, a common way in which people do fail that bisphosphonate. Why anabolics? Because they increase fusion rate, they decrease time to fusion, they increase insertional torque, and they decrease subsidence. And they do all this without changing DEXA scan. So don't be worried about the DEXA. Don't track the DEXA. Know you're doing it. Start it 6 to 12 weeks before surgery. Longer if you have worse bone or more time. Trying to keep at least 6 months on the backside of surgery, because it's also causing them to be pro-metabolic while they're on the medication. And you want that when they're trying to make bone for the fusion. Intraoperatively, above and beyond the medications you do before and the whole BHO process we talked about, less bone, more metal. So circumferential, anterior lateral versus all posterior. Why? Because the surface area of anterior lateral cages is about 3 times that of an inner body that you place from the back. More contact area equals less stress. It's not a fraternity at the top there. That's the equation for stress equals force divided by area of contact. Also, when you come to the front, you wind up releasing the structure that is the restraint to getting lordotic correction. So the anterior annulus, the ALL, are either cut out with an ALIF or loosened with the lateral lumbar. And then optimize your graft. We want to fuse faster, and you want to fuse better, so we're taking the stress off our implants. And so on that osteobiologic continuum in which grafts live, don't be far left, which is dead bone, go far right. High density constructs, more screws, maybe bioactive coatings on those screws. Maybe you can get spot welding, because again, the failure point is the bone implant interface. Cementing, you can decide. I can give you articles for it. I can give you articles against it. My interpretation is that it stops pull out and proximal junctional failure or kyphotic type failures early, but not forever. It just displaces them by 3 to 5 years. I think the work out of Hopkins is the best on that topic. So I'm not a big fan of cement because it's very hard to work around if you have to fix something later. Coming soon and somewhat here now, modulus matching. Remember, the stiffness of the material dictates how it's going to interplay with the things it touches. PEEK is a lot like bone. Carbon fiber is a lot like, sorry, PEEK's a lot like cancellous bone. Carbon fiber is a lot like cortical bone. And then 3D printed titanium is like a lot more than both of those, 5 to 10 times harder. And then maybe end plate matching, which brings the idea of custom implants. So where you're actually getting a larger cross-sectional area, and as a result, you're more surface to share the load and reduce the stress. Let gravity be your friend. So don't use persuaders. You need to bend the rod so it fits the screws. You need to use the table either by pushing on the back to produce lordosis or by using an axis table to drive them into lordosis. Don't expect that you can make older patients with softer bone respond to your screws as well. This is a nice paper that was at this year's Academy by Cox, in which they saw that if you just lay someone on the table unintentionally, you lose 20% of their lordosis in the lateral position. So you got to be intentional about producing a lordosis when you tape them in. Make sure your screws are harmonious, that they connect the dots, and so you don't have ones that are off so that you don't have to use persuaders. That might be a good indication for navigational robotics because it might get those heads where they need to be. There's a lot of places you can put a screw in the bone. There's only one where the head is next to the next head. And then more rods is not the answer for these patients because the rod is not the weak link. It's not the metal, it's the metal to bone. Fusion's a race between biomechanics and biology. You got to win the race. The way you win the race is by more metal early and by putting osteogenically active grafts. And so I'm a big user of far right grafts in these particular patients. And then unfortunately, as we saw with Keith's patient, once you get this right, it's a never-ending circle of challenges. Sarcopenia is another issue. That patient certainly has that. Medical comorbidities. And so all we can do is keep hoping that we find the reasons that people fail our surgeries, do what we can before surgery, and then drive on the next. We are a victim of our own successes. The more we do, the more patients expect. Bone health is certainly something we should pay attention to. And demand the best for your patients. A better surgery at the first time is definitely cheaper in the long run than a cheaper surgery the first time. Look for, do your BHO before, get them on anabolics if it's indicated, anterior posterior approaches, and highly osteoinductive grafts. Thanks.
Thanks, Brett. We're going to turn it over to Scott to get a little bit more into detail about the intraoperative techniques for hopefully making these things work a little better.
All right, there we go. Perfect. Let's see. Sorry, I got a big thing coming right across my screen. Second here. Let's try that again. There we go. All right, so kind of expanding on Brett's talk there, he touched on a lot of this stuff, but we're going to talk about some of these intraoperative strategies we have to kind of get some success when we're dealing with this very difficult population of patients. I love this study because this looks at patients who had pseudoarthroses, and over 80% of those patients had some kind of metabolic problem. Chief among those was osteoporosis. So it's not a problem that is rare or is going to go away anytime soon. And preoperative optimization is probably the most important factor that we can do to mitigate things, but it's really not the only factor. Again, as we mentioned, there's different things we can do intraoperatively as an adjunct to that. And the other thing to keep in mind is a lot of times we don't actually have an option to optimize our patients. We get patients who come in all the time that need surgery urgently. We don't have 2, 3, 6 months to optimize a patient for a big elective case. So this is a patient, 68 years old, was doing fine, fell from standing, had back pain, numbness, tingling in his legs, some new onset weakness, getting progressively worse, right? So I don't think anybody disagrees that that this patient needs something in the OR. And it's interesting, you look at the studies, that lesion, that big lytic lesion there at T1011, is probably nothing that was new. It was probably there. And interestingly, I put that coronal MRI up on the bottom right there because he's got what turned out to be a very large malignant pleural effusion. So, I mean, those were his studies, laying down the scanner. And here you can see, obviously, he's in fairly significant kyphosis when you get him upright. So again, that lesion probably wasn't new, but that fall was probably all it took to just push him over the brink. So what do you do with this patient? Because we can't send them for bone health optimization. There's a lot of challenges when we're dealing with open surgery, right? So the bone is terrible. So whether we're trying to correct this patient's kyphoscoliosis here, or whether we're dealing with an acute fracture, we got to worry about the risk of screws pulling out. We have to worry about our bone grafts, our interbodies, and structural grafts subsiding into the bone. So it's a lot of challenge. And again, everything we do surgically is around two things, really, which is improving the fixation that we can get, as well as improving the fusion. So our surgical goals are the same as pretty much anything, right? We want to provide rigid fixation. We want to promote fusion. But we need to do that in a way that best prevents our hardware from failing, and in a way that does not create any new problems for us. So there's a lot of factors that we have control over intraoperatively. It's how many levels do we decide we want to fuse? How many screws are we going to put in? How are we going to orient those screws, or what sort of technique we're going to use to put those screws in? We have control over the alignment of that patient, whether we're deliberately doing a deformity correction or whether we're just treating a fracture or treating something else and making sure that our alignment is good. Other adjuncts and different ways we can improve our fixation and decrease the stress at the bone hardware interface. And again, the control over really how we get our fusion. How much surface do we have, or how well do we prepare those surfaces, and what do we use to get fusion? So maybe 20 years ago, people started looking at using HA-coated screws, which might be nice, and they have increased pull-out strength, but don't really help us out in an acute situation. It takes a while for bone to grow onto them. So as far as kind of finding ways to augment our screw fixation directly, cement augmentation really has kind of been the only option we have to go to. There's two ways of doing it. You can prepare your screw tracks, then inject the cement, and then insert a solid screw, or you can use a cannulated and fenestrated screw, insert the screw, and then inject the cement through the screw. And there's kind of advantages and disadvantages of both. I really like this study. This is Ted Choma's study from a few years ago, and it's because he didn't look at just one thing, but looked at a couple of different variables in how we put screws in. He looked at whether or not we tapped the screw track versus leaving it untapped, whether we oriented the screws straight in or angled them a little bit cephalad to get fixation distally in the sort of thicker subchondral bone under the end plates, and whether or not it was cement augmented. And interestingly, what they found was that tapping was probably better, but only if you were planning on cement augmenting. So if you look at the table here, if you're not going to augment the screws, the more you tap, the greater depth you tap to, actually the weaker the bone got. And it's the exact opposite pattern if you tap and then inject cement before entering your screw in. And interestingly, the trajectory matters too. So the quality of bone, perhaps, that you're putting the screws into, whereas the cephalad augment trajectory was superior, particularly when these patients had cement augmentation. And that was more of a biomechanical study, but looking at clinical studies, and again, Brett alluded to the fact that you can find a study that'll support pretty much anything. But looking at clinical studies on this, with cement augmentation, we found higher fusion rates, less risk of screw loosening, and generally speaking, good clinical outcomes in osteoporotic patients. Now, one other adjunct, and again, this isn't quite available in the US, at least not to my knowledge. I don't think we have any approved systems here, but is using expandable screws. And the concept here is really similar to putting in a drywall anchor or putting a molly into plaster. There's a device that actually will allow the distal end of the screw to expand a little bit and create some resistance theoretically for pullout. This was a clinical study comparing patients who used either a fenestrated screw with cement augmentation versus just an expandable screw. And they found no difference in their clinical outcomes or their or patient satisfaction of the outcomes, and no difference in what they called stability, which is interesting to me just because the article didn't ever once mention the word fusion. They just called it stability. So I don't know if they ever actually assessed true bony fusion in that study. We mentioned earlier that trajectory might play a difference. So this study looked at the use of cortical bone trajectory screws, which are generally shorter. They actually looked at 3 different trajectories. So traditional trajectories with cement augmentation, the more classic cortical bone trajectory, which is generally a shorter screw, and then something called the midline cortical trajectory, so a little bit longer screw. And what they found was that the augmented traditional screws had the greatest pullout strength, but if cement was not an option, they felt that the midline cortical trajectory was reasonable. This study actually built on that one and went back and looked now at the midline cortical trajectory versus non-augmented traditional screws. And interestingly, in their dynamic testing, found over half of the traditional screws failed under 10,000 cycles, as opposed to none of the cortical screws in this setting. And that's because the screws tend to rock in that cancellous bone, right? And they give that sort of windshield wiper effect that we're used to seeing on x-rays. So again, if you're going to not augment your screws, these authors at least felt that the midline cortical was really the best option for that. In addition to putting screws in, we've got a lot of other things we can do. So again, the goal is decreasing the overall stress of the construct. So fixing to multiple different levels and getting multiple points of fixation. There are techniques to add additional stability, particularly at the ends of the construct if we need it. So a little bit older technique perhaps on the right here is a sublaminar wire. You can do this with a tether going around the kind of under the lamina and around the screw. A technique that I've used from time to time is this one, which I really like, which is a combination of an offset hook and a pedicle screw at the same level. So it's an offset laminar hook, kind of upgoing hook in there. You add a little bit of compression to upload it all. It's a way of getting extra points of fixation without necessarily fusing extra levels. And tends to work pretty nicely. And interestingly, we didn't really talk about this much, but in patients with osteoporosis, the laminar bone tends to still be pretty good. So there is some strength there. And obviously, pelvic fixation helps out, particularly with long constructs or any patients that are at high risk for failure. And again, if we're doing long deformity surgeries, some evidence that the S2AI screws generally are going to provide stronger fixation, less risk of failure. And that kind of goes in with the next topic here, which is keeping an eye on our sagittal balance. So it's interesting, if you try and look up osteoporotic spine surgery in the cervical spine, there's next to nothing that you can look at. But I thought this was interesting because they were looking at rates of adjacent segment degeneration. And obviously, if you're with a high post-op surgical SVA and osteoporosis, that led to increased adjacent segment degeneration. More commonly, we're thinking of this in terms of deformity surgeries, and this was more of a biomechanical study. Again, looked at different situations with either sort of a perfectly neutral SVA +5 or +10 millimeters. And they looked at 2 different constructs, either going from T2 to S2 or from T10 to S2, and then either using a pedicle screw, or a transverse hook at the UIV. Not surprisingly, as the SVA increased, so did the stress on both the vertebrae and the implants. Interestingly, the UIV stress was highest with the shorter construct, with going T10 to pelvis as opposed to T2. But there was decreased stress at the UIV with the addition of a hook as opposed to the screw. So we know that, having good sagittal balance here is going to have less stress on the overall construct. You don't want to have a situation like this one on the bottom here where the screws just where the bone just pulled off of the screws, basically. When we're trying to correct deformity, again, that's something that has to be done very gently and very carefully. You really cannot force the reduction to the rod, where the screw is going to pull straight out of the bone, and you're going to be miserable. So kind of, again, as Brett alluded to with these with these patients, the key here a lot of times is patience, with a C, trying to give yourself time. You can't rush through this. You got to take your time and really only gently correct them. And the anterior column support, with a 360 fusion is obviously very helpful. It increases the load sharing, so it decreases the strain posteriorly. But again, you've got to be concerned about the risk of cage settling. We talked a little bit about modulus, and interesting, as the cage modulus decreases, the stress on the end plates decreases, but kind of concurrently the posterior stress goes up. So it's a matter of watching that balance there. And really, the advice, again, remember that your pressure is the same as force over area. So use a cage with a wide footprint. I tend to favor lateral fusions if I can, because it's a big, long cage and it sits on the ring apophysis, which is a little bit stronger bone than just somewhere in the middle of the end plate. So a little bit less risk of settling. All right, so that is that's sort of the tips and tricks on what to do to improve our hardware and fixation. But the other aspect of this is the fusion, and this gets into the biologic component of it. I'm gonna skip through some of this just for the sake of time, and so we have some time for discussion to get through the basic science part of it. But when you look at sort of this cascade, cellularly, where what happens with bone formation, you've got all sorts of signaling cytokines and things that initiate the process, but it has to happen in the bone. And the problem with osteoporosis is not so much a problem with bone biology per se, it's that there isn't enough bone. It's a quantitative problem. And so if we want to treat this from a fusion factor, at the level of the bone, we need to either prevent the bone from losing, create more bone, or potentially this is a place to consider using cellular allografts. And the data on that, again, it's not great unless you're a rat. There's just not a whole lot of data, but these top two studies looked at a rat ovarectomy model, and with using cellular allografts, they found better quality bone, increased bone density, more bone trabeculae, and pretty good fusion rates. So much that it kind of overcame the osteoporosis. The bottom study is actually a clinical study and using a cellular allograft. And again, they didn't look specifically at osteoporotic patients, but in a cohort of patients that have all sorts of other risk factors for pseudoarthrosis, they were able to get excellent fusion rates using the cellular allograft. But it's not all unicorns and rainbows, right? So this is a different model, used a different type of osteoporosis, so dexamethasone-induced osteoporosis, and found that the stem cells did not actually migrate to the surface or differentiate in the osteoblasts. So it's not just enough to have cells, but you have to get those cells to work. And so that's where your osteoinductive agents come in. And the most common one that we think of is BMP2 or Infuse. Again, the top two are rat ovarectomy models, and again found excellent fusion rates using BMP, able to overcome the impact of the osteoporosis. The bottom study looked at P15 bound to an anergenic bone matrix, or which is what I-factor is, if you're familiar with that as the brand name. And again, in the osteoporotic rats in that study, there was significantly increased bone formation. So perhaps that helps. All right, so where does that leave us at the end of the day? Here's our patient that we don't have a chance to make perfect. So what do we do with this? I just, again, sticking kind of with the principles that we did. He got a nice big decompression because of a spinal cord injury. Um, had a anterior strut placed in there, multiple levels of cement augmented screws, with some good bone biologics thrown in for good measure. So again, the principles we adhered to with this case: multiple levels of fixation, cement augmentation of screws, anterior column support. He's got a pretty good overall sagittal balance there. If you remember, this was sort of thoracolumbar area. I think it was T10-11. I do a very wide exposure on these. These are open surgeries, not percutaneous. So I had the TPs exposed at every level, and the lamina sort of proximal distal where I did the laminectomy. So plenty of space to lay down bone, and again, used bone biologics. So again, optimization is ideal, but it's not always possible. The goal with our techniques is really to minimize the stress that you have on really weak bone. And biologics are hopefully going to help, be very helpful here, because at the end of the day, again, as Brett said, and to reiterate it, is the race between biology and biomechanics really is the difference between fusion and failure. All right. Thanks.
Thank you, Scott. So we will go back to this case, and I mentioned that have not done it yet. So what would your plan be? She's got a lot of mechanical back pain. She's got radiculopathy and neurogenic claudication, but it's isolated to the L2-3 level. I guess the first question is optimization strategy, Brett. You're sending her to an endocrinologist at your institution. What agent are you guys most likely to choose?
Good question. So, she's osteoporotic. She's severely osteoporotic, minus 3.0 or worse. And so she's indicated for first-line treatment with an anabolic. She could get any of the three. My personal experience in the United States, she's 63, so she might be under regular insurance. And so if she were 65 plus, it's more than likely she would get on Evenity, and that has to do with reimbursement. I'm okay with any of the three. That's what I tell all the patients. And our endocrinologists have written these prescriptions enough. They have a sense of this insurance company covers that, or that one covers this. They also are aware of the two drug ones, Tymlos and Forteo, oftentimes run rebates to try and be competitive to that access to care issue. So for me, I don't care which one of the three. This is not a tomorrow disease like Scott's case. And so I would probably err on the side of at least 3 months. You want to have several bone cycles before you tackle this. But to answer your question, Keith, I would say that any of the three in our institute now, it's probably going to be Evenity for this one.
So Evenity, and that's what she's on. I'm erroring long, but not necessarily because of the bone, but because of the weight. How much weight do you want her to have? Is there a total protein, or is there a BMI, or
Yeah. So when your albumin gets below 3.2, bad things happen. And so you want to be well above that. So that's a little metric you can use. Another metric you can use, the prealbumin, and so that's something that lets you know, are you making a difference? Because it takes a while to change your albumin levels. So both of those can be done. Prealbumin can change. It's almost like CRP versus ESR. It's a little bit quicker demonstration for you. It's hard to tell people to gain weight, especially a bulimic. I don't know. We've had to do this before. I get scared of skin. You can see, I'm imagining the axial images of the MRI or the CT. I guess you weren't able to get MRI. You're going to see less than a centimeter of soft tissue between the top of the head and the skin, and that worries me. She looked like a pretty open central decompression, or maybe that was Scott's case, but I don't know if we saw your axial images, but when they have a big open central canal and you're going to look to make your left and right turn quickly so you don't get into the exposed dura, that reduces the amount of soft tissue. So she is as much of a problem in sarcopenia. And that's also probably why she's not standing up as well as what, in addition to her bone. Her low lumbar lordosis looks like it's probably 35. And so it wasn't too far off to, for her. Yeah, so Evenity is what I'd use, and the sarcopenia piece is send them to nutrition, high protein intake, and then work with your nutritionist on what labs they think, but albumin and prealbumin are the ones that we use.
Yeah, I think you hit a good point there with sarcopenia. Her pelvic incidence lumbar lordosis mismatch is only 20 degrees. But she's 8 centimeters positive. And so I keep going back and measuring both of those angles. I find it a little bit, sometimes maybe a little bit more challenging to measure lumbar lordosis in a patient with some scoliosis or whatever, but that's kind of what I've got. So I didn't anticipate her having the magnitude of sagittal imbalance that just from looking at her lumbopelvic parameters.
Mm-hmm.
What do you think, Scott? So you talked to us about surgical strategies. What's going to be your strategy with her?
First of all, I'll just say if weight gain is an issue, you just need to send her to West Virginia because we never have an issue with that here.
Yeah.
Although the quality of the quality of the weight is a little bit different. We've got plenty of fat people that are malnourished, and I think the sarcopenia also. I think that does play into this as well as just not so much true sarcopenia, but just she's had a couple surgeries back there already, so her paraspinal muscle has been stripped a couple times, so that always factors into it as well. I think surgically speaking, if I remember correctly, her only stenosis was at that L2-3 level, which I think fit with, I can't remember her neurologic symptoms, but it seemed like it was about right.
Yeah.
And so, part of me wants to say that less is more with her. I still, optimization, pre-op optimization is not just for massive deformity surgeries. I mean, ideally you do it even for a 1 or 2 level procedure as well. So, the key here is going to be trying to restore her lordosis and, to a reasonable degree, or else she's just going to keep falling off on top. But your PIL mismatch isn't bad. So surgically speaking with this, I'm thinking kind of a 360 approach with it in one sense. I think I probably would do a lateral at 2-3. Maybe some Pontes there, posteriorly, and maybe at 1-2, and then, fuser. I don't know if I would go any higher than T12 fusing her down. I probably would stop at, 1, even if, probably cross a junction, but it's not going to be a huge surgery for me. The smaller the surgery, that generally speaking, the less likelihood of having some horrible complication. So I don't know, Brett, you may opt to go big on this.
Oh, no. I think that, I might even just do a 1 level add-on. So
Yeah.
the disease you're going to win on in her is stenosis, right? And if she's leaning forward because of stenosis, if she has a substantial leg symptom, you're a little bit screwed also on the last surgery because he's, it's about 10 degrees, off to the right side, and trying to figure out how to correct for that. And one of the problems with a lateral is it's very powerful because it's a level thing. And so when you stick that in, it's going to want to sort of push her off from left to right. And she already looks like, if any, she's a little bit right of center as it is. So, I think the smallest you could do is an add-on at 2-3. And then that's the least amount of work you need to do on the bone. If I would not go above the low thoracic, although I liked your article a lot about the increased stress on T10 versus upper thoracic, and that makes sense in my practice. But she is a little neutral through a thoracolumbar spine, so I think you could stop at T11. I usually stop with a rib, not a small guy. So, and I don't stop at the junction. I might this is someone you got to, she's not done with surgery. So she's not done with a picture that would make you want to do surgery, whether you end at T12, T11, or T10. And so I would rather make this next picture not much different than the current one, but make her better. So I would start at L2 and then make some rational reason on why I have to go above that, to be honest with you.
So yeah, and that's kind of where we are. She's on Evenity now. She's been on that. She started on Verteo. But we're working on weight gain. We're working on the protein parameters, particularly the albumin, and she's getting there. I've actually got her on the books. I was considering going up to the 2 levels, but coronal balance, coronal plane deformity is really not an issue for her. Not the issue she's complaining of. She looks okay from that perspective. And so I was planning on doing L2-3 for a couple of reasons. Number one, for the reasons Brett said, but the other reason is that when we look at her imaging, I would probably come in from a lateral from the right side on at L2-3 because she's so collapsed at L1-2. I just worry about getting into the end plate at that level, and I think I can more easily do it from the convexity instead of the concavity, which I usually prefer. And L1-2 would probably be easier from the other side. So the plan right now tentatively is to take her up 1 level with an indirect with a lateral and then tie her in from the back. We'll probably do an open decompression as well because that's the other thing about these osteoporotic patients. I think they get better, but maybe never perfect, and I worry about using indirect decompression as my only means of decompressing the nerves, which is our big complaint. So typically try to use the biggest lateral I can. I'm not a big fan of tapping screws if I don't have to. In these osteoporotic patients, use the biggest screws I can. She's got small pedicles, so I expect to get some cortical engagement, and use the longest pedicle screws I can. And so that's the plan for nothing heroic, just a 1 level case, maybe back at some point in the near to distant future. But I'm hopeful that when she comes back, she'll be happy that her leg pain was gone for some period of time.
And the only thing I'd say is following up on Scott's point, and you don't know what it's going to happen at 2-3 till you stick a parallel cage in there, parallel in the coronal. It's going to be lordotic, and maybe it'd be a high lordotic, and that'd be great. And I wouldn't do any type of release anteriorly. You just get what you get. So 12 is better than, or maybe 16, but nothing huge. But is that it may push her a fair amount. She's, what is she, 1 centimeter? I imagine she's 1 centimeter right of center.
Yeah.
If she winds up 3, then things are, it's a little bit different. And then if you look at where her center sacral line goes to now, 11, 12 is sort of where you're going to intersect it, as she sits on the table right now or stands. So I would be prepared if you didn't like where she wound up coronally after surgery, because you're not going to be able to correct that coronal shift with just the 1 level. So that's the only thing I would add, because if she starts tilting, then she puts extra stress on the entire system. So, but I think that this is a great case. All the cases that were presented so far are great cases because they point out the fact that there's so many different elements that go into this, and you can try and optimize the bone. And we only get 1 good shot with the antibiotics. That's another reason to maybe think about going longer. It's funny, the more I talk about these cases, and we do this same indications conference, the more it keeps sort of walking up the spine. But you got to rein yourself in. I love what you did in the first place. Is the very first thing I got to do is treat the stenosis. Do I need to do anything more? Hopefully, and probably not. But be prepared for the second thing you might need to do just in case.
Well, hey guys, I think I'm tracking that we are getting up. The witching hour is approaching. I want to kind of cross advertise a few of the upcoming events. We have the spine case consult series going. These are great opportunities. If anybody has any cases, email someone from the AO or AO Spine, or email the moderators, or just connect with someone from AO, or even on the reminders, and let them know you got a case. It would be wonderful to have cases that aren't our own to discuss. And so take that opportunity, even if you don't have questions, even if it's just a gee whiz, look what I did kind of thing, or if you just need a second set of eyes on things. Those are coming up. We've got the Grabowski squad March 19th and April 1st. And we have a couple more webinars in 2020 in the near future. We've got an adult spinal deformity. We've got a technical navigation. There's an MIS webinar coming up, and cut off the presses, and likely a medical legal one later in the fall. So lots of good opportunities to learn and engage in with the AO. I'd like to thank again the faculty. Those were fantastic presentations. I love hearing both of these guys talk about this topic because I always feel like I learned something. And I hope you did too. Thank y'all.